they told me I have to start right at 2, so we've got like 2 minutes, because I think they're televising this or something like that, so. Streaming, not televising, yeah. That's old-fashioned. Hi. I don't. Perfect, that'll work. Or people can scream, one or the other. Good point, good point. And is this an hour or an hour and a half? Does anyone know that? 1 hour? Okay, all right. Okay, perfect. Thank you. It's a big room. Otherwise, you'll be running a lot. That's it. That confuses Goldilocks even, right? All right, so I'll go ahead and get started. Well, thank you guys for coming out, and also thank the Myositis Association for dragging me out to this horrible location for a weekend. It's a little bit nicer weather than Phoenix, by the way, which has still been 110 and killing me. Okay, so probably most of you are here actually to hear a lot about myositis research, and so I'm going to get to that at the end of the talk, but I can tell you if anybody wants to leave really quickly, there's a great website. So I actually meant to add it as a slide, and I think I forgot at the end. So if everyone doesn't know about the site called clinicaltrials.gov, you should write that down, and that's really where you need to go. And that would actually save you from having to listen to me for an hour. And so it is any clinical study that's being done in the US has to register onto that website. And so you could go on once a week, once a month, plug in myositis, dermatomyositis, polymyositis, and you'll see every research trial that's going on in the country. So really, that's how I stay up to date with what's going on, and so you can do the same thing. So I will talk a bit about research at the end, but I thought what I would do, and you unfortunately are going to have to deal with the fact that whenever people ask me to do a talk, and I haven't done that talk before, the first time I give it, I never really know how it's going to go. So you guys are a bit of my guinea pigs. But I thought, and I've spoken here at the Myositis Association before, I think a lot of times we kind of jump to the research part and we don't focus so much on the understanding part. And I thought what I'd like to do is to really spend a little bit more time talking today about understanding muscle. So all of you have a problem with muscle. If all of you had a problem with your heart, we kind of understand the heart. The heart's pretty simple, right? It is a muscle, it beats. It has blood vessels. That's pretty much the two problems you get with the heart. Muscles are very, very complex. There are, in fact, more known diseases of muscle than any other organ system. So both inherited and acquired muscle diseases, there are more of the muscle than there are for the kidney, the lung, the heart, by far. So it's a very, very complex system. So I thought what I would do is to start by talking about what muscle is and what it's supposed to do. So muscle has a number of different functions. So we like to think that muscle has to contract to be able to exert force. So muscle gives us energy. But we have to have our muscles excited at the right amount. And so there are, in fact, diseases where your muscles can't be excited, or diseases where your muscles are too excited. And so there is a sweet spot, which is where normal muscle is supposed to be in terms of it being excited and relaxing. Because if your muscles always were excited, you would walk around with your muscles stiff all the time, and that exists, and that's not very good. You then have to have the muscles be able to lengthen correctly, and then also shorten correctly when you contract your muscles. And so these are very, very important functions. The other thing to understand is that there is no muscle that pushes. So muscles only pull, right? So if you have a biceps, your biceps is pulling. When you exert your triceps are pulling. we actually can't push. The function they do can be to push, but muscles only contract. That's what they do, they pull. So how do muscles do that? Well, muscles need a lot of help to do that. And it turns out to be very important to understand that, because when we talk about the different forms of myositis, it's not necessarily always an attack on the muscle fiber itself that's causing the muscle disease. Sometimes it's an attack on the other parts of the muscle that you need to allow your muscle to contract. So what do you need for your muscle to work? Well, number one, you need a nerve. So a muscle without a nerve isn't going to do you any good. That nerve has to tell the muscle to contract, and it has to do it in an orderly way. The second thing, obviously, is that muscles need energy. So we know that when we exercise, we know that if we have malnutrition, our muscles weaken very quickly. And the muscles are affected very, very quickly by a lack of energy. So if you have decreased nutrition for as little as 3 days, your muscles already start to suffer from that. So the muscles need really a continuous stream of energy. And the energy it gets is really predominantly sugar, but also fat, and then obviously oxygen. So your muscles have to have those in order to be able to contract correctly. And then they have to be able to get rid of their waste. So any cell that we have in our body uses energy, it produces energy just like a power plant, but when it does so, just like a power plant, there is waste that comes from that. And you have to get rid of that waste in order to keep that muscle fiber healthy, or that muscle fiber is going to die because basically the toxic waste builds up. And we know a lot of different muscle diseases where that occurs as well. And then all of that has to be held together. So if you think about, and I'll show you a picture here in a second, if you think about steak, steak is held together, right? I mean, it is a single piece of meat. Meat is muscle, right, obviously. And all of that white stuff, which is usually my favorite stuff, is what we call the fascia, okay, or you can call it fat. But the fascia serves a very important function, because the fascia is what holds the muscle fibers together, okay? And particularly when we talk about dermatomyositis, you're going to see that this may in fact be more of an attack on the fascia, not allowing the muscle fibers to function correctly, than it is actually an attack on the muscles themselves. So all the different parts of that, the blood vessels, the fascia, the energy delivery, the energy removal, all have to be perfect, or the muscle fibers can't work. So we have a variety of different layers of fascia. So we have what we call the superficial fascia, which is kind of closest to the skin. And so if you think about going right underneath your biceps, right, you'd have a layer of fascia, and then you would hit your muscle. That's the superficial fascia. That's where our fat is, unfortunately. But that's a very important function, the superficial fascia, because it actually protects us. It also gives us temperature regulation. So it allows us not to be too hot or too cold in this room, or to be too hot or too cold in this room, is the fact that you have fat and superficial fascia to regulate your body temperature. That's where that function occurs. But the most important thing about the superficial fascia is that's where the blood vessels are. So the blood vessels that supply your muscles are going to run in that superficial fascia. So when you damage that fascia, you're then going to damage the blood vessels, which therefore leads to decreased energy being provided to your muscles. And that's, as I said, particularly in dermatomyositis, we think that that's very important. And then underneath the fascia, the superficial fascia, we have the deep fascia. And this is really what kind of surrounds the individual muscle fibers themselves. And I'll show you a better picture of that in a second. So when we talk about muscle, like the biceps, we're not talking about one cell. We're talking about hundreds or thousands of individual cells. And those individual muscle cells, you can call muscle cells, or the word that we use is myofibers, okay? And these are very unique cells in our body. So most cells in our body, if you think about it, have one nucleus. So the nucleus in a cell is what kind of regulates the cell, tells the cell all the proteins it needs to make. But because a muscle fiber may run the entire length of my arm, that's a very long cell. And a single nucleus is not able to really do that correctly. So that single muscle fiber will have multiple nuclei. And there's kind of regions of the muscle fiber that each nuclei then controls in terms of producing the right proteins and so forth that muscle fiber needs to survive. So this is sort of what that looks like. I always sort of think back to telephone wires, because to me that's how this kind of looks. right? So we might talk about a wire that goes to your house, but you know that in that wire there are hundreds or thousands of wires. That's the way nerves and muscles are both sort of arranged. It's gonna be hard, I think, with the PowerPointer here. But so this would be the muscle itself. It connects to the bone through the tendon. So when you damage a tendon, the reason that your muscle hurts is that it's no longer really connected correctly. If you think about like the Achilles tendon, which we're all sort of used to seeing people injure, if that ruptured completely, the muscle would no longer be connected to the bone, and the muscle can't do anything because it can't move that bone. Now, in that individual muscle, you can see that there's lots and lots of individual muscle fiber cells. These are arranged in little, what we call fascicles. So of those thousands of muscle fibers, we now get them down to tens or hundreds into an individual fascicle. And each of those fascicles is supplied by a little blood vessel that runs in the fascia. And so that's sort of the organization of the muscle. And all of that has to be able to work correctly in order for our muscle to work correctly. So if we start to look a little closer at what these muscles look like, it turns out that they're arranged in this really strange kind of striated pattern, okay? And I'm going to show you sort of what that means in a second. But you've got a nerve here. That nerve comes and lands on the muscle fiber, and then that nerve is what's going to tell that muscle fiber that it's time to contract. And so if you actually look at a real electron microscopic picture of that, these are individual muscle fibers. You can kind of get a sense of these striations, and I'll explain that again in a second, but these black lines are each individual nerve coming down, sitting on that muscle fiber, telling that muscle fiber when and when not to contract. So this is why it looks like this striations. So inside that muscle fiber, there has to be an apparatus or a system that allows the muscles to stretch and contract. And so that system really is best explained as kind of two overlapping railroad tracks, okay? So there are two very important proteins. Oops, go back. Two very important proteins that are involved in this. One is called actin, and one is called myosin. And the distance between each of these is called a sarcomere. And so this is the actual picture, looking at a very high power image of the muscle fiber. And this is kind of a cartoon of what you're looking at right here. And each of these sarcomeres is what actually contracts. So I'll show you what that looks like in a second. So here's a relaxed sarcomere. Here's the myosin, and here's the actin. So when your muscle fiber is not contracting, your proteins are kind of separated just a little bit. And then when that nerve signal comes in and says, okay, it's time for those muscle fibers to contract, then what happens is they contract, and they pull together. And then when they relax, they're going to pull apart, and they're going to pull together. And that's the single most important function of muscles. So everything that our muscles do in terms of the blood vessels and the energy, and I'll show you in a second, the movement of certain salts and so forth, all that is designed to get actin and myosin to come together and relax. So these are the two most important proteins to allow our muscles to have strength. So the whole length of a single muscle fiber contracts at one time. So if you think back to that image of the nerve coming onto the muscle fiber, when that nerve sends the signal, that whole muscle fiber goes and contracts. But the muscle fiber right next to it doesn't have to. So if I move my thumb just a teeny little bit, I don't need to activate all my muscle fibers in that thumb muscle to do that. I'm just going to activate a couple of them. And so again, based on what my brain is telling my nerves then tell my muscles, I just need a few of my muscle fibers to contract. And then the more you need, the more muscle fibers start to get pulled in. If you're trying to lift something heavy, you're going to pull in all of your muscle fibers. Okay, so just one more sort of basic kind of concept in terms of how muscle fibers contract. And the whole point of this for me, the reason I wanted to kind of go over this with you is that this is really complicated. And I think very often when people have myositis, they think, oh, I've got some inflammation in my muscles. That's very, very simple. It is really, really complicated, this whole system. So just to go through it now. So this is, again, a cartoon. So here's a nerve, and here's your muscle fiber. So it turns out that the nerve, even though I showed you that picture of the nerve coming down and talking to the muscle fiber, It turns out the nerve doesn't touch the muscle fiber. So in order for the nerve to tell the muscle fiber to move, the nerve has to release chemicals. And on the muscle fiber, these blue things are specific receptors for those chemicals. So it's actually the release of those chemicals and then the binding of those chemicals to the muscle fiber that then tells the muscle fiber to contract. Okay? It seems like it would be simpler just to have the nerve sit on the muscle fiber, but it doesn't. Now, that in and of itself does not make the muscle fiber contract. But that then serves as a signal inside the muscle fiber to release calcium. And calcium is sort of the key transmitter inside the muscle fiber that tells the muscle fibers to contract. And so remember I told you it's the actin and the myosin that have to come together to make the muscle fibers contract. What signals those two proteins to start sliding over one another is in fact the release of calcium. And that release of calcium is signaled by this binding, which is signaled by this nerve signal. So it's a very, very complicated system. Defects anywhere in there have and been described and cause muscle weakness. So you can have defects where you don't release enough of that chemical. You can have defects where you don't have enough of these receptors. You can have defects where the release of calcium malfunctions. You can have lots and lots of defects in these proteins, actin and myosin. All of those cause muscle weakness. So it's as I said, it's important, I think, to kind of understand when we start to get to the basis of, well, how are we going to fix these types of myositis, that even though we know that there's inflammation in the muscles, that may not be the primary problem in some or any of these diseases. The other concept just to kind of keep in mind that you might have heard of is that when it comes to muscle fibers, there are also different types of muscle fibers. So the amount of force that an individual muscle fiber can exert actually can differ from one to another. And so we call those slow twitch and fast twitch fibers. And each person will have a different ratio of slow twitch and fast twitch fibers. So it turns out that the fast twitch fibers are the ones that allow us to move very, very quickly. So if you're a sprinter or a weightlifter and you got to cling and jerk 500 pounds, you need fast twitch fibers, okay? The people that are probably very good at those sports were probably born with a lot of fast twitch fibers. That's what allows them to do that. But those fibers fatigue very, very quickly. And part of the difference is that they use glucose. So glucose is a very quick fuel source, right? If you need to sugar boost, glucose does it for you, right? On the other hand, slow twitch fibers are what allow us to do something for a long period of time, right? So the Kenyan runners, those guys have incredible slow twitch fibers because they can go run 5-minute miles all day long. And what's interesting is that although you can build muscle fibers and you can build slow twitch or you can build fast twitch fibers, it's very, very difficult, if not impossible, to switch the number of slow twitch to fast twitch that you have. So if you were born to be a sprinter, you're probably born to be a sprinter and not a marathon runner. And in the slow twitch fibers, they tend to use a lot more fat for fuel, which is, again, that's our longer term fuel source. But they don't get nearly as much power as you need right away. Okay, so I figured you guys probably hadn't heard that sort of basic muscle talk before, so I hope that wasn't terribly boring. But it is actually really interesting. And to me, I think the reason it's interesting is that as we start to think about myositis research, the take-home message from this is we have no idea what we're doing. So I think that, and the reason is that we don't have an understanding of what causes a problem. So in neurology, we train for 4 years to become a neurologist. What we're told is that you can't begin to solve a problem until you can localize the problem, right? So if a person's weak, is their brain causing the problem or are their muscles causing a problem? Well, what causes a brain problem is very different than what causes a muscle problem. So if I don't know which it is, I'm never going to help that person. So in myositis, we know that the muscle's the problem, okay? But with all these different steps and complex systems that are in place, we have no understanding as to which of those steps is really the problem. And so that's why it's a little bit like throwing darts at a board and hoping we get lucky when it comes to research. Because we're like, oh, well, this kind of makes sense. And then it doesn't. And then we just keep throwing more darts and doing more trials. So it is clearly, the basic science of these things have to advance before we're really going to have the answers. But I thought I'd start with talking a little bit about where we are with the current understanding of myositis research. So this is just sort of a slide to give you an idea of the types of inflammatory myopathies that there are and the way that we currently think of their prevalence. So we used to think that polymyositis was much more common than we now think it is. Probably in large part that's because we put a lot of diseases into polymyositis that were not. So lots of muscular dystrophies, lots of metabolic disorders. We just weren't smart enough 30 years ago to know that. Now we sort of do, and it turns out that poly is pretty rare. Dermato is common. Necrotizing myopathy is probably more common, and then these sort of overlapped or mixed connective tissue diseases are common as well. So I was going to talk a bit about the main types of myositis, and the point here for you to take away is that these are very, very different diseases. So on the one hand, you guys are all at the same meeting, which is great, and that's a great thing. The bad thing is we tend to use all of the same medicines for all of your diseases, even though we really understand that they're very, very different diseases. And again, that's just because we don't have enough understanding of what's really going on. So I'm going to take you through kind of the pathology. So one of the advantages and one of the reasons that we are actually a little bit further down the road with muscle diseases than with others is it's not terribly difficult to biopsy muscle. I know you guys hated it probably, but it's a whole lot easier than biopsying brain, for example, right? So we get a lot of pathology and we get to look at a lot of muscle biopsies without a ton of difficulty, which is good. So let's talk about polymyositis. So this is, if you look at this part of this muscle fiber, this is a pretty healthy looking muscle fiber. It's fat and it's pink. Okay, that's the way we like these muscle fibers to look. But on the edge of this muscle fiber, we see that these blue dots have come in and are eating up the muscle fiber. And so those are what we call T cells. T cells are a part of the immune system, okay? T cells are what gets affected in HIV or T cell lymphoma. Lots and lots of diseases that are related to the immune system affect the T cells. So if you look at this picture, you'd say that something made these T cells really angry. And what made them angry is probably inside that muscle fiber because they're coming in and they're trying to eat up that muscle fiber. And that's kind of our current understanding of polymyositis, which is that it's an autoimmune disease. A person's immune system, their T cells get activated, and that immune disease is directed against something in the muscle fibers themselves. And so when we look at the muscle biopsies, we see all these blue dots are cells of the immune system, inflammatory cells. We see lots and lots of inflammation. So the attack in polymyositis, we think, is definitely on the muscle fibers themselves. Now, in dermatomyositis, it's very different. So here are these muscle fibers. Now you say, well, these don't look quite as pink, and these look like different shades of pink, okay? And then the other thing you notice is that this area right here has got a lot of those blue dots. And this is that paramysium. This is the connective tissue. And what's important to remember about that connective tissue in dermatomyositis is this is where the blood vessels run. The other thing that's important is that a lot of these cells are not T cells, but they're actually B cells. So it's a different type of cell. It's a different type of cell. The attack doesn't seem to be on the muscle. In fact, if you look at the muscle, there's almost no inflammation in the muscle. But what you do see is the muscle's not very pink. And the reason it's not very pink is that when you attack the blood vessels, now the muscle fibers can't get enough blood, and they're ischemic, or they're starved of energy. And so what we see instead in dermatomyositis is more of what we call a vasculitis, which is an attack on the blood vessels, which therefore damages the muscles kind of as a secondary effect, because they're deprived of blood. So that's sort of our current understanding of dermatomyositis. But you can see that's a completely different pathology than the pathology that we see in people with polymyositis. Now, inclusion body myositis, again, has a completely different pathology. So now we look at the muscle fibers, and there is inflammation, okay? But if you look at these cells where there's inflammation, those cells are pretty much dead already, right? Those are small, shrunken, very sick-looking cells. Next to it, here's a pretty healthy-looking cell. And then there are these cells that have the inclusions, and you can see these inclusions. You don't see those inclusions in poly or dermatomyositis. Now, back about 20 years ago, there was a ton of research because people decided we need to understand what's in those inclusions. Something has to be there. And so they would do all kinds of stains and all kinds of studies, and pretty much everything they look for is in the inclusions. So that turns out not to be very, very helpful. So all of the proteins that a cell normally makes, those are contained inside those inclusions. So the theory, again, we may not be correct or we may be, but the theory is that this muscle fiber has some kind of problem with its internal processing. And remember I said that cells have to make these proteins and degrade the proteins, and make the proteins and degrade the proteins. More and more, we're beginning to understand that malfunctioning in the way in which proteins are degraded, or at least in the balance of production and destruction, may end up being the basis for a lot of our diseases. So inclusion body myositis is one of those. Alzheimer's disease is one of those. Parkinson's disease is one of those. ALS is one of those. Where when you look inside the cell, what you see are these big blobs of proteins that should be destroyed and cleared out by the normal processes of the cell, but they don't. And so at some point, it's not hard to imagine that this big blob of protein is now going to get in the way of the functioning of that cell. And our body has a normal defense mechanism. If you damage a cell to the point that the cell can't repair itself, now your body has to come in and clean that cell out and kill it, okay? And there's a whole system that's in place for that. So basically what we see are pretty healthy looking cells that are developing these inclusions, and then really sick dead cells where the body's immune system has come in to clean them out. But that's why we believe that inclusion body myositis is not primarily an autoimmune disease. So in poly and dermatomyositis, it's the immune system which has decided to attack the muscles or attack the blood vessels. In inclusion body myositis, the primary problem may be inside the muscle itself in one of those steps that I described, and then it's the immune system that's just coming in to clean out a dead or dying cell. And that's why multiple research trials that are designed to prevent inflammation, steroids, IVIG, chemotherapy, don't really work in IBM. Because if you stop the inflammation, you don't stop the fact that the cell is going to die anyway. And that's just the way our body normally behaves when we've got something that's dying. And then finally, so the newest kid on the block is this one that we call necrotizing myopathy. So this one's even more confusing because here, the cells basically all give up the ghost. So there is some trigger that causes these cells to just die. And what you can see is there is no inflammation, okay? There are none of those blue dots in this biopsy. But all of these cells are way under pink, right? They're way too pale. This is maybe okay here. These are all what we call necrotic cells. And when we say necrotic, that's what we mean. Think about a dying piece of flesh. That's what's happened here. These muscles have just died. And there are two basic reasons why this occurs. One is there are many drugs that can trigger this to happen. And the most common are the cholesterol-lowering drugs. So we've known about that for 30, 40 years now. It could happen right when you start the drugs the first time. It could happen 10 years later. We don't know why. But at some point, that drug just becomes a toxin to the muscle. The muscle can't produce any more energy, and the muscle just all dies. Okay, now, if you biopsy this person a month from now, you'd see a lot of inflammation because, again, the inflammatory cells are going to come in and clean up the dead cells, but the cells are dead. We now know there's also an autoimmune form of necrotizing myopathy. And that's an important disease to be aware of because, again, the longer you allow this to go on untreated, the more necrotic cells you're going to have, and that may not be completely reversible once you do start to treat them. And then, again, to sort of highlight how much we're learning, but at the same time how confused we are about this whole system, so I showed you 4 forms of myositis, completely different pathologies, and then we now understand that in many of these diseases, patients will develop autoantibodies. So antibodies that are supposed to fight bacteria and viruses in a person's system that instead seem to be markers for the disease. We don't think they cause the disease necessarily, but they're markers for the disease. So for example, in IBM, this is the most recent one on the block, there's now a new antibody that's been discovered in IBM. So I told you, well, we don't think IBM is an autoimmune disease. Well, some really great people at Hopkins and the NIH have now found that a large percentage of people with IBM do in fact have an autoantibody, which is a marker for the disease. Why is that? We don't know. You could come here, over here, these 2 autoantibodies, SRP and then the HMG-CoA reductase autoantibody. those are antibodies that are found in people with necrotizing myopathies. All of these antibodies, including Jo1, are the ones that are found in people that have lung disease. These are ones that are found in people that have skin disease. These are ones that are found in people that have a paraneoplastic disease, meaning that a small percentage of people with myositis can actually have a cancer that may be the initial trigger to cause the autoimmune syndrome. And those people tend to have these antibodies. So that's all really exciting, and it's actually been very, very helpful to our research over the last 10 years or so as we've started to understand this whole system of these autoantibodies. But what doesn't make much sense, at least to me, and no one's been able to explain it to me, is that you can have these with dermato or poly, dermato or poly, dermato or poly. So I told you the pathology is completely different, right? And that we think it's not the same disease whatsoever, but you can have Jo1 antibodies and lung disease with dermato. You can have Jo1 antibodies and lung disease with poly. This one is very specific for IBM. This one's more specific. This one seems to be very specific for the necrotizing myopathies. But a lot of these really kind of blur the lines between poly and dermatomyositis. So on the one hand, you've got a group of researchers who, like myself, prefer to be splitters and tend to say, well, you got to put people into the smallest bucket possible and then study that small bucket, because if you study everybody together, you may be missing a group of people that get better. But then there are people that show this and go, well, if all these people that have all these antibodies can be poly or dermato, maybe this is the point, and it is the same disease. It's just something different about that person in terms of how it's being expressed. And we don't have the answer to that. At least none of us have the answer to that yet. So that was kind of my point. It's confusing. And then the last point, here, which is, again, the frustrating thing for me and for us, is that because we don't have a lot of medicines and because we don't have the understanding of what causes the disease, we basically throw the same drugs at everybody. Again, IBM different, but necrotizing, poly, and dermato, which look completely different, different triggers, everything different. We only have sort of a handful of drugs and we throw them the same at the people, which again doesn't make much sense because these should be different diseases. So just to talk about the current landscape, and then we'll talk a little bit more about the newer trials that are going on. So these are basically the drugs that we use. I think that despite the side effects, most people believe that steroids, again, for poly, dermato, and necrotizing are the place to start. Probably the most successful in terms of percentage of patients that improve, but very limited because the side effects are terrible. And then the longer you're on them, the worse the side effects get. And with these diseases, you tend to have to be on them for a while. So I'll go through most of these one by one. So the steroids are, in fact, great medicines. They're really the best anti-inflammatory medicine that we have. They're cheap, which is great. They're easy because they're a pill. And as I said, they're very effective. One of the things that's so frustrating about myositis treatment at the moment is that we really have almost nothing that's approved by the FDA to treat it. Almost everything is off-label. The only two that have a label indication are glucocorticoids, and then I'll show you a drug called ACTHAR, or ACTH. Everything else is off-label and has not been studied. Again, that doesn't mean it doesn't work. It just means it hasn't been studied in a large enough study that was positive to be proven to the FDA to be effective. Most of the studies with glucocorticoids are surprisingly poor. They're not really good studies, and so if you were trying to get the FDA to approve them in 2017 based on this data, they wouldn't. Most of the steroid indications came in the 50s and 60s when the FDA had a completely different approval process than it currently does. As I said, the real problem with steroids is just the side effects. So everybody gains weight. Everybody gets puffy in their face. If you're on them for long enough, you will become diabetic. If you're diabetic now, it's going to make the diabetes terrible. It's really bad for bones. It causes cataracts. It causes mood change. It causes ulcers. I always tell people, I use a ton of steroids, despite what I just said to you. But I always tell people when I put them on steroids, I said, this is very different than every other drug we use, because every other drug, doctors go, oh, take this. 99% of people do fine. Don't worry about it. Don't read the thing you get from Walgreens. With steroids, everybody gets side effects. Okay, so it's not the possibility of side effects. Everybody gets side effects. Rheumatologists and neurologists, as you know, are probably the two main groups that treat myositis. We've always had a little bit of a difference. We all start with steroids, but rheumatologists have always been much bigger fans of methotrexate than neurologists have been. I don't really know why. I think it's because they used to use it a lot for lupus and rheumatoid arthritis, so they're very comfortable with it. I over the last 10 years, have begun to like methotrexate a lot more. So it's relatively cheap. It's a pill. It's once a week, so that makes it convenient to take. And there's been a little bit of data, again, not great studies, but a little bit of data that it works. And side effect wise, kind of you follow the kidney, the liver, there's a little bit of risk of it causing some lung disease. And so once a year, you just need a chest x-ray. But this is a nice medicine for people to use. Azathioprine is one that neurologists have tended to like a little bit more. Again, well tolerated for the most part. The biggest downside to azathioprine is about 5% of people are allergic to it. So you'll start it in the first week or two, feel terrible. There is a blood test that you can do. It's actually an enzyme that people are missing that causes that. I actually tend not to do it because it's very expensive and it's hard to get. I just put people on it and if they feel terrible, they stop it. But some people will get the blood test first. Cellcept or mycophenolate has been sort of a neurology favorite. Despite the fact that this is very widely used, there actually are very poor studies, and I do use it, but there are very poor studies in terms of whether this works or not. It's pretty well tolerated, again. You follow kidney and liver function. And in some of the studies in myositis, if you add Cellcept, people can lower the dose of the prednisone. So most of these drugs that I just showed you are really drugs that we call steroid-sparing drugs, so that we want to get people onto therapy quickly. Steroids work very quickly, and then we want to try to get them off the steroids, which then means they need something in addition. So the rheumatologist will start prednisone and methotrexate with the hope that they get better quickly from the prednisone, then they can get them off the prednisone and just continue the methotrexate. The other drugs basically work the same way as well. IVIG is a medication that many of us like, probably many people here have used. So it is antibodies from other people. So when people donate plasma, that plasma becomes a bunch of things. So it becomes vaccinations for rabies, it becomes the Rh factor for pregnant women, it becomes clotting factors for hemophiliacs, and the antibodies become gamma globulin. The gamma globulin can be given intravenously or it can be given subcutaneously. None of us really know how IVIG works. We use it in dozens of diseases despite no clear understanding. What I tell patients, just because it makes sense to me, is that if there's something bad in your immune system, if we flood your system with other people's antibodies, it will block that thing that's bad in your immune system. It doesn't stop the thing that's bad in your immune system. So this stuff stays in your body about 3 to 4 weeks. And therefore, after 3 to 4 weeks, the effect wears off and you have to get it again. So the downsides to IVIG are that you have to get an infusion monthly, typically, and that it's very, very expensive. The upside to it is that it has very, very little side effects and really almost no long-term side effects, whereas all those other drugs I just showed you have significant long-term side effects. There is a study now I helped design looking at IVIG to try to get an indication for myositis. It's been very difficult in the last 5 years or so to get IVIG approved for myositis because there's no good trial. I think the largest trial was like 15 patients. We're working with Octapharma to develop or have developed and are starting a trial to look at the treatment of myositis with IVIG. I think most of us believe it works, and so therefore we hope the trial works. We have believed that about other drugs before, and then the trial not work, which always is like shooting yourself in the foot, unfortunately. But this is a very exciting trial because if it works, as we hope it will, it would then lead to Octagam being indicated for dermatomyositis, and then really kind of open up the world of that, because right now it's very difficult. Rituximab, which was another trial, this was the one that we shot ourselves in the foot with, unfortunately. So I actually published some of the earliest research using rituximab in dermatomyositis. Chet Otis, Rohit Agarwal, Lisa Ryder, Fred Miller, I helped a little, they did most of the work, designed the largest trial ever in myositis, so over 200 patients. It was a massive amount of work, which Chet should get an incredible amount of credit for, incredibly well done. Sadly, we probably designed the trial wrong, and so what we did was to give people rituximab and placebo, and we did that for 8 weeks. And then we said at the end of 8 weeks, did the people that got rituximab do any better than the people that got placebo? And the answer was no. But then at 8 weeks, to be ethical, everybody got rituximab. So the groups switched. So if you'd gotten rituximab initially, you went to placebo. If you got placebo, you went to rituximab. At the end of the study, which I think was 9 months, 80% of the people in both groups got better. So the study probably showed that rituximab worked, but it doesn't work as fast as 8 weeks. That led to, and still has led to, more difficulty getting rituximab approved. So it was published in the New England Journal because it was such a well-done study, but it was a negative study. And therefore the insurance companies can point to that and go, well, rituximab doesn't work, and then we have to explain why we designed the study wrong. So that has been a little bit of a challenge. In terms of some of the other drugs, cyclosporine is an older drug that we use, and there's been, again, some retrospective studies. I think this is often one that people will use if there's a lot of lung disease involved, as well as tacrolimus, a similar drug. Again, particularly Chet Otis at Pittsburgh has published some very nice work showing that those two drugs are very effective for people that have the interstitial lung disease, typically in addition to prednisone and maybe even in addition to IVIG. Cyclophosphamide can be given orally or intravenously. To me, this is sort of my last rescue for poly and dermatomyositis patients. So if they've failed steroids, methotrexate, IVIG, rituximab, and you're sort of, CPK is still 15,000 and you don't know what else to do, this is really a strong chemotherapy agent. So it's given once a month for 6 months like a chemotherapy drug would. And it can be very effective, but it is like chemotherapy. So people lose their hair, get sick, that sort of stuff. And then ACTH, I actually published the initial 5-patient retrospective series and then a 20-some patient series. ACTH is the hormone that causes our body to make steroids. And so in the 1950s, before people could make synthetic prednisone, and we knew we needed to give people prednisone, we would give them ACTH because we could make that from pigs. Just take pig brains, isolate the ACTH, stick it in a person, and then the person's own glands would make lots of prednisone. So this has been around for forever. And as I said, this is the only other drug that has an indication for poly and dermatomyositis. It's very much a historical thing. It kind of hung on from the 50s or 60s, but it can be very effective. I've had some really good successes with this, again, sort of later in the course of the disease. It's a subcutaneous injection that patients give themselves. Seems to have, for most people, less side effects than steroids because it's their own steroids as opposed to taking external steroids. Many people still use this as well. So this is kind of a baseline treatment approach to myositis. For mild disease, most people would start with prednisone or some type of corticosteroid. Again, this will be polydermato, maybe necrotizing, although you don't really have a mild necrotizing myositis. But, and then if they're doing well over the next couple of months, then slowly start to taper the prednisone. Some people, when we're in that tapering process, will follow the muscle enzymes to see how much further we can taper. I'm not a big believer in that. I tend to follow a person's strength. I'm not treating a lab test. I'm treating their strength. So if somebody's feeling a lot better and they're more active, their muscle enzymes can go up because they're more active. So if you check the muscle enzymes in a marathon runner after a marathon, it'll be 3,000 to 5,000. They don't have a muscle disease, obviously. So again, to me, if you're getting stronger, staying stronger, that's really what you want to follow. If people have more significant disease, most people would start again with steroids and then really add one of those oral steroid-sparing drugs at the same time. So methotrexate, azathioprine, Cellcept, then see how patients are doing. Then if they're not doing well, then you need to start to look towards kind of third-line drugs. And it is important. So muscles do a great job of shrinking and contracting, right? So if you're a couch potato for a couple of weeks because you're doing a lot of work, your muscles get weaker. And if you exercise for a couple of months, your muscles get stronger. But once a muscle fiber dies, it gets replaced by fat. And once it's replaced by fat, it can't come back. And you can't make new muscle fibers. So treating polydermato and necrotizing early and aggressively is very important because you want to prevent the loss of the muscle fibers because those don't recover. Okay, so this is actually what you guys came for. Sorry, it was 45 minutes of what you didn't want to hear. But this is relatively short, unfortunately. So, as I said, the good news is there's a lot of research into all the different forms of myositis. And it seems like the money is flowing, which is obviously what drives the research. And so I do think we're going to get better drugs. I've been involved in, 5 myositis trials ongoing in the last 2-3 years, which is more than the 10 years before that. So I think it's actually a really, really good time. The bad news is we're still throwing darts at a board. We still don't really know what we need to hit or what we need to target. That's the bad news. So there's a number of interesting trials that are going on now. Most of these top 4 are really designed to look at different parts of the immune system. So the idea is, again, in polydermato and necrotizing myositis, we do think that the immune system is the most important piece of that we understand at the moment. One of the problems with the immune system is that it's really built to kind of fail. So in other words, if you're starting to lose one part of your immune system, another part of the immune system can come around and pick it up. And so what tends to happen in a lot of these diseases is, yeah, we can knock out TNF, but then IL-12 goes up. And so there's so many different proteins, cytokines, and so forth involved. I'm not 100% convinced any of these are going to sort of be the holy grail. Ideally, some of these will really slow or change the disease course, but we're still not at that sort of starting point, if you will. So these are all good trials that are going on. We're involved in a couple of them as well. Here are some other ones, again, going on. These are all immune system related. Here's the Octagam study, which we're really literally all praying. If it's negative, I'm just going to be so sad because, again, it's going to be very reflective then of what happened to the rituximab thing, which is if it doesn't work, the insurance companies will all point to that and go, you did the trial, it doesn't work. And we all know it does work, but we're optimistic. There is a small subcutaneous trial, so that gamma globulin, doesn't really matter how you give it. It just has to get into the body. IV is a little convenient because you can get it in 1 or 2 days a month. If you use subcutaneous, you can do smaller doses. Very helpful. Sometimes the IV does have a lot of side effects, headache, fever, chills. By doing smaller doses more regularly, then those side effects usually go away, so I do like that. The other thing that's nice about the sub-Q is that you can do it at home by yourself. So there's a lot of home health companies that will come give you the IVIG, but you still have some nurse in your house 4 or 5 hours a day. Some people actually like that. But otherwise you could or you're traveling, you could take it by yourself. So the sub-Q offers a lot of flexibility. And then IDERA is doing the tail end of a study. They're here today. We were part of this study as well. This is actually a very cool trial. So it's a very, very interesting molecule, really specific for dermatomyositis. So we don't know the results. In fact, I'm not sure if they're in the room, they can answer, but it's at the tail end. So we should probably have those results within, I say, 6 months, a year, certainly. But this could be a very unique, a medicine that patients might eventually be able to give themselves and target, again, a very specific part of the immune system that we think is important in dermatomyositis. So this was an exciting drug. In IBM, we've got a little bit less. So all of those are really for poly and dermatomyositis. Probably the most exciting thing on an IBM research front at the moment is this drug called arimoclomol. There's a branch of the FDA called the Orphan Product Development Branch, OPD. IBM is considered an orphan disease, and so Dr. Barron and Dr. Damashki at the University of Kansas did a small pilot trial of 24 patients. We were one of the sites of that that showed that arimoclomol was well tolerated, so it seems to be very safe. it blocks a specific protein kind of involved in sort of cell death. So again, if you think about IBM as a disease where maybe the cells are being triggered to start that whole death sequence, or there's something bad in terms of how they're regulating the proteins, this particular protein called heat shock protein is not necessarily a bad target. So this trial actually should be starting, I think, later this year, but certainly by the first quarter of next year for sure. But they got $1.6 million actually from the FDA to do that trial, which I think will be the largest trial in IBM ever done. So that's actually really exciting. There are some other approaches in IBM that people have been considering. So there's a really smart company called Cytokinetics. I always like novel companies. I don't think they're here. But they have a number of different products. I think like 6 or 8 different products. And their products, remember I talked about how that calcium is all what triggers the moving of the actin and the myosin? Their products are all designed to improve that in some way. So they developed one product, which I think is about to get FDA approved, which is for cardiac muscle. So people that have congestive heart failure, where their hearts don't beat strong enough, they can actually make the patient's muscles beat stronger. They did a trial in Lou Gehrig's disease. Again, they're not fixing Lou Gehrig's disease, but even in Lou Gehrig's disease, this drug can make the muscles beat or contract stronger. So they actually are starting a trial in IBM to see whether or not they can, again, they're not going to fix the underlying problem. It's almost more of a symptomatic treatment. But if we can make you stronger, who cares, right? So that would be great. And then this has actually been, so you probably heard in previous years, Jerry Mendel, who's been just an amazing researcher for 50 years now in Cleveland, has a gene called follistatin that he's been using in IBM. And this is brilliant. So this is 20 years probably ahead of where we are, but he's done it. So some of you may remember about 10 or 15 years ago, there was a little boy in Russia. And he was born, and as he developed, like at age 1 and 2, he looked like a bodybuilder. His muscles just were massive, massive, massive muscles. And it turned out that his dad was like an Olympic weightlifter and his mom was an Olympic weightlifter. And when they tried to study this, because his muscles wouldn't stop growing, when they tried to study what was wrong with him, it turns out that there's a protein inside our muscles that stops our muscles from getting too big, right? I mean, again, if you kept working out and your muscles kept growing, eventually you wouldn't be able to breathe or do anything because you'd just be one giant muscle. So it turns out there's a gene that stops your muscles from doing that. And he had inherited 2 bad copies. So the reason his mom and his dad were both so strong was they had 1 bad copy, okay? But he got 2 bad copies, so he could not stop his muscles from growing. So that has become an enormous source of research for the last 10 or 15 years trying to understand that gene. Because again, if we could make your muscles stop growing, your muscles would grow. And so Jerry has been doing research in IBM patients, just injecting a single muscle, so just the quadriceps muscle, to see whether or not we can get people to be stronger. His rat research is incredible. So if he injects one thigh of a rat and not the other rat, the one rat looks like Arnold Schwarzenegger's thigh, and the other rat looks normal, or the thigh looks normal. So. All right, so I'm trying to 10 minutes for questions. I think unfortunately, well, the good news again is I think there's a ton of research in myositis, and we're starting to have, Jerry Mendel's work is great. We've got a lot of new products for poly and dermatomyositis. We're still a little bit at the sledgehammer or dartboard stage because we need more basic research. We need to understand really what's kind of causing these diseases. And the other thing we have to do is we have to start studying them very separately, which we have. So, even 10 years ago, we studied poly and dermato together. There are very few trials now that lump those together because we do think that they're completely different diseases. And again, you may, depending on how many of which you enroll, if the drug is successful for the other group, we might lose seeing that benefit. And then I think, again, we have to follow people with time. So there's more and more, I think, research being done as well, just to see what happens with people's progression. So what happens with these diseases over 5, 10, or 20 years. And that can tell us a lot about what's happening inside the muscle. So I'll stop there. Yeah.
Thank you. This is my 6th conference, and kind of every year we sit here and hope and hope and hope, and we're kind of, in some ways, where we were 6 years ago. Obviously, we're not. We're a lot smarter. But I'm coming at this, I guess, from a different angle today in my question to you, sir. And that is, in between these years that we come, I'm trying to maintain as much as I can.
Yeah.
And one of the reasons, obviously, is clinical trials, so that I don't get to a point where I'm going to become ineligible. Given your deep understanding of muscles, and you talked about contraction, one of the things that I have been utilizing for about the last year, and just started it on my neck, but has been neuromuscular electrical stimulation, which in theory, and again, I put in quotes, in theory, causes some contraction. When I have approached other doctors in your field, the response is, we don't have any data on this. And my response is, well, how do you get data without doing some type of evaluation with this? And so it becomes a circular discussion, if you will. So let me stop there and just kind of ask you what you think of the efficacy. Well, let me come at it just a different way real quick, and that is, if you were my neighbor and you were a doctor, given all you know and all the contacts you've got, and you had what I've got, I'm just curious what you would be doing yourself to keep yourself as whole as you can.
So it's a very complicated question. So I'll answer it really simply, which is what I typically do when I have complicated questions. Be healthy. So eat well, exercise. Same thing that you would do if you didn't have a muscle disease. And I don't mean that, I know that sounds slightly facetious, I don't mean it to be, but so that's the simple answer. But the reason I say that is this, which is there's very little reason to believe that anything that anybody with myositis does to a sick muscle will make that muscle stronger without treatment. So take a dermatomyositis patient whose CK is 10,000. Unless you give them steroids, no matter how much exercise they do, they are not going to get better, okay? Take an IBM patient whose quadriceps are so weak that they can't extend their knee. There's no amount of exercise that's going to make that better. I've never seen that happen, okay? But take that IBM patient whose quadriceps is that way. So how do they walk? Well, they walk because they use their hip muscles and their calf muscles, which may not be nearly as damaged. And so those muscles can get stronger. So the real answer, my belief, again, there is no data, but my belief is that you can't make those muscles that looked as bad as I show you in the pictures stronger. But you can make any of the other muscles stronger that aren't that bad. Now, I don't know which ones are that bad and which ones aren't, okay? So do some amount of exercise to keep yourself healthy. Do some amount of exercise to work on your balance so you don't fall and break a hip. Eat right, and I'm going to be in the dysphagia talk next. We'll talk about that. But really, that's the answer. Now, do any of these other things that people say hurt you? No. Does the neuromuscular stimulation hurt you in any way? Absolutely not. So I don't mind people trying all that. And you know, it's sort of like those abs of steel commercials, right? I mean, if you stimulate your muscles enough and they contract enough, if they're healthy enough, they'll get stronger. So I do believe that. But I also believe that when they're damaged or dead, as I said, once they're replaced by fat, that you can't make that stronger. Yeah. But so I think a lot of that is how you compensate for it. And those muscles do need to be kept as healthy as possible, which is eating good and doing some exercise. So that's my, as I said, I know it's a simple answer, but I think that, you know, I've been doing it 25 years. It's kind of the way I see things. So if it were me, to answer your question, I'd probably spend an hour a day doing some series of exercises, which hopefully I would do anyway, I do now, and I would eat well, which is what I hopefully do now. So, I don't know. Yeah. But we do need data, sorry.
So I have a DM with interstitial lung disease. I'm newly diagnosed in April, and I actually had the first symptoms were secondary Raynaud's and peripheral neuropathy that came out. And nobody for the most part, it seems to be abnormal, but yet then when I talk to other people, they do talk about some neuropathy. So I'd really love to find out, is anybody studying neuropathy with this?
Really good
and
question.
if I go into remission, is the neuropathy going to go away? Because the numbness and tingling is worse than the muscle wasting for me.
So, well, it's a hard question too. Without going into personal issues for you, I think very often, so there's a couple of issues. One is people can have neuropathic symptoms, so pain, burning, stabbing, without necessarily having nerve damage. When we say neuropathy, we mean that there's nerve damage, and we would study that by studying the nerves. So very frequently in the setting of your immune system going completely out of whack, which is what's happened, people may have these other kinds of neuropathic symptoms. Yeah, numbness and tingling. And then some of the medicines, in fact, can cause numbness and tingling. On the other hand, if you've had a test that actually shows that those nerves are damaged and that you definitely didn't have this before, then that would suggest to me that what's causing the nerve disease is also kind of related to your immune system, and that's very common. Yeah, so again, particularly, so you think about when a person's immune disease goes out of whack, typically it affects one organ, muscle, right? For you, it's muscle and lung. And if it starts to do that to two organs, there's no reason to think it couldn't do it to a third. I don't see that very often, but it's also not very far-fetched for me to believe. And the hope then would be that as they get your immune system down, right, that the neuropathy would get better the same way the muscle and the lungs do. Yeah.
Our internist is suggesting that and I think he promotes it because he's doing it himself, a plant-based diet. What's your view on that and a non-plant-based diet? And we can go either way.
Yeah, so I'm probably a bad person to ask. So I'm just not a big believer. I'm going to go back to the simple thing, just be healthy. Right, so I mean, you want to live the quality of life that you want to live. So if you want to live a plant-based life diet or a paleo diet or gluten-free diet, I got no problem. I mean, all those are healthy. But I don't think there's any data, so again, or any reason for me to believe. I never tell patients to change their diet. And in fact, the only change that you might consider making, and the data is not there, is just obviously more protein. So more protein. So muscles need protein. And so there were studies done 10, 15, 20 years ago where people took lots of what's called creatine. So bodybuilders will take a creatine powder. The main protein in muscles is creatine. So for them, when they need, 200 grams of protein a day. Yeah.
Any differences in cultures that are more plant-based versus, say, Japan? They tend to eat a little less meat, more fish.
I don't.
In terms of developing myositis.
Not that I know of.
No.
They certainly have myositis in the East. Yeah. So some people will do extra creatine. You can do it as a powder or a shake. You could just eat a little more protein in your diet. But again, the studies of that weren't really beneficial. But if you said to me, if I was going to do one thing different if I had myositis, it'd just be to make sure I got enough protein in my diet. Again, to me, that's just healthy though, right? Again, if you're trying to work out and build muscle, just like if you were a bodybuilder, then you would be eating more protein in your diet. So if your goal is to work out and build muscle, you probably don't want to be in a protein-free diet, right? That would be bad. So.
Yeah, I just wanted to ask about, there was a report recently in the newspaper, and I don't remember the details, but it was someone from Europe who had an autoimmune disease who purposely went to Africa and got himself some kind of thing that did it on purpose, some kind of thing that the immune system would focus on. I don't know if it was a worm or an infection or something. And the theory being that it would help his autoimmune disease, and in fact it did. Are you familiar with that? It gave the immune system work, in other words. I'm
not. The only thing that I'm familiar with of any size where people did that significantly was the bee venom. So bees. So people, it was a big thing for MS about 20 or 30 years ago. It was the same theory. The theory was if you would stimulate the immune system to react against the bee venom by getting stung by bees, you would stop your immune system from reacting against the brain in MS. They did study that a little bit, and it didn't seem to work, and so that kind of faded out. So that sort of distraction, if you will, that's the only thing I know of that, it's hard to know. Again, many, unfortunately not myositis, But there are many, many diseases, actually including some forms of myositis, that are single, or what we call monophasic, right? So a person wakes up as a terrible muscle, develops horrible muscle disease, CK's 100,000, they spend 6 months recovering, and it's gone, right? We think some of those are post-viral, triggering the immune system. So if a person who had that, or some form of that, and we see that affecting the brain, the nerves, the muscle, everything. But if you were in that phase and you went and drank green tea, you'd go, oh, my green tea cured me. I'm like, well, no, you were going to get better anyway. But he got a nice trip to Africa, maybe. I don't know.
We have time for maybe 1 or 2 more questions. Go ahead.
Is there a institution or location where I could get current information on the statin-induced necrotizing version?
There's a lot written about it.
I'm thinking of a central one, maybe a doctor.
Does the TMA have a brochure on it?
I'm not sure. Do you know, Chris?
If not, we should make one.
Yeah.
There's a great website that actually was from where I trained. It's neuromuscular .wustl.edu. So it's Dr. Alan Pestrunk. It is the single greatest neuromuscular website in the world, actually. And if you go onto that one and you look up statin myopathies, it'd be a few pages, but that would give you. It's neuromuscular, so N-E-U-R-O, muscular, and then .wustl.edu. It's an amazing website. It's free for anybody to use, and actually everything about muscles on there, everything. So.
This is the last comment, and it's just a comment. I enjoyed your lecture immensely, and your first talk about how the muscle works and how it all puts together. I have never heard it.
Good.
And it was very, very interesting. Thank you.
Thanks. Oh, you guys are my guinea pig, so I guess it was okay.